It's my distinct pleasure to introduce Dr. Vladimir Carli, Associate Professor of Psychiatry and the Deputy Director of the National Center for Suicide Research and Prevention of Mental Ill Health at Karolinska Institute in Sweden. Dr. Carli has taken a leadership role in several major organizations with commitments to suicide prevention. He is co-director of the WHO Collaborating Center for Research, Training, and Methods Development in Suicide Prevention. He is chair of section of suicidology of the World Psychiatric Association, and he is a board member and treasurer of the International Academy of Suicide Research. Dr. Carli has co-authored more than 100 original scientific papers published in international scientific journals. His main research areas of interest are in the field of e-delivery of suicide preventive interventions, development and evaluation of interventions for young people, development of collaborative online tools for researchers in suicidology, development of statistical methods for the evaluation of suicide risk. Dr. Carli was also a key investigator on the landmark study, Saving and Empowering Young Lives in Europe, also known as SEYLE. SEYLE was a multi-center randomized trial designed to investigate the efficacy of school-based mental health promotion and suicide preventive interventions. The research project was led by Karolinska Institute in Stockholm and was funded by the EU under the 7th Framework Program. Dr. Carli will be discussing this in his presentation. And so without further ado, here's Dr. Carli.
Thank you very much for the introduction. In the meanwhile, I discovered another technical problem that I'm not allowed to share my slides. So that's a problem, of course. I wonder if, host disabled participant screen sharing. I mean, I can.
I'm adding it to the chat. Maybe they'll see it.
Yeah, I wrote it as, yeah, okay. Okay, but I can start maybe with talking about, I mean, it's not the best situation. Okay, now that's maybe they fix it now, sorry. Okay, can you see my screen?
Yes.
Perfect. Okay, so thank you for the introduction. So I will talk a bit about the role of schools in promoting and strengthening mental health and well-being for children and adolescents. And I will speak also about the SEYLE project that was mentioned before. It's a bit of a long presentation, so I mean, please feel free to ask questions if you have any, even during my presentation. That's perfectly fine for me. So let's start a bit in general about childhood and adolescence. We know that there are crucial periods that actually lay out the foundation for a healthy development and good mental health as adults. It's time to, it's the time when we develop and acknowledge, develop knowledge and skills. We learn to manage emotions and relationships. We acquire new abilities, and it's extremely important because everything that we do in adolescence then has a lot of relevant positive and negative repercussions for our adult lives and adult roles. So let's start from saying that we ask children and adolescents to perform a lot of tasks in schools and outside schools. So we ask them to achieve from the academic point of view. We ask them to work in a cooperative manner. We ask them to make responsible decisions about social and health practices. We ask them to contribute to their family and community. And at the same time, we ask them to resist negative influences from peers and media. And we ask them to interact effectively in a society that it's increasingly diverse. So it's a lot. And the role at school, of schools, it's very important because school have the role of fostering knowledgeable, responsible, and caring students. So knowledgeable, we mean by that they should be motivated to learn and then able to integrate the new information with their lives. We want them to be responsible, so be able to understand risks and opportunities, and be able to choose actions and behaviors that are important for themselves, but not only for themselves, but also for others and for the community. And moreover, we want them to be able to see beyond themselves and being, as I mentioned before, part of a community. In this context, school, it's very important, and health in general, even before we go to mental health, because health and education are intrinsically linked for a number of reasons. First of all, healthy children are more likely to learn effectively. Education plays an important role in the health outcomes throughout life. So we know that people who have higher education level also have higher, better health and mental health outcomes. And we also know that not only the students are important, but we know that promoting the health of school staff, it's important and can lead to more effective teachers, to a greater work satisfaction, and reduced absenteeism, all of which are very important for the growth and development of children. And this is known by many years, actually. So we know since pretty relevant amount of time that school health, it's important. But we had, more recently, we actually shifted our approach about how activities for health promotion are undertaken in schools. So before, children were mostly taught about health. So they were giving mostly information about health and its determinants. And we were focusing more on single health topics like nutrition, smoking, physical activity, and so on. While today, we have a bit of a different approach, that it's not only to deliver information, but it's to enable children to develop skills and strategies so that they can avoid unhealthy lifestyles. And we also have more holistic goals. So we understand that actually to promote health and mental health, we cannot focus on only on the students, but we have to focus also on the health of everyone that is involved in school activities. That means students, staff, and even parents. So why do we focus on schools for mental health promotion? So there are a number of issues. Some of them are related to the school itself. The first one, it's one of the most important, actually. School is the place where teens spend the majority of their waking hours outside of home. So it's a place where we actually do find the majority of young people. So it's a place that increases the outreach of interventions and that are performed. Schools, it's also a familiar and hopefully safe context in which taking the discussion about health and mental health. And it is a setting that it's already devoted to the development of personal skills. and also allows for an early detection of those young people that are at risk. And we have other school specific factors that are related to mental health and are specifically important in schools. One of these is bullying and peer victimization, unsupporting teacher-student relationships, poor climate in the classroom or in the schools, and low level of connectedness between students and between the different people that actually are in the school to study or to work. Now I'm going a bit in general into this, but then later on during this presentation, I will present also some data that support all of this. And when we do mental health any kind of initiative related to mental health in school, it's important to take into account that intervention should be well designed and grounded in tested theory and practice. So it's important that they are evidence-based. It's important that they adapt to the school environment. So we can't change what the school already offers. So whatever intervention we offer in school should be feasible in the school setting without too relevant transformations or changes to it. It's important that they foster respectful and supporting relationships, of course, among students, but also with teachers and parents. As much as possible, they should use approaches to teaching that are interactive, and they should also they should help to develop improvements in achievement, in academic achievement, in social and emotional skills, and decrease anxiety, depression, and other mental health factors, and improve the classroom behavior. And we also hope that they produce significant benefits in relation to reductions in aggressive behavior, school dropout rates, and building a sense of community in the school. So just to mention this, I hope you all know what mental health gap is. It's a program by the World Health Organization about recommendations for conditions that are defined as priority conditions by the WHO. And among these, there is suicide. And so in the section of mental health gap about suicide, there is a specific recommendation about suicide prevention programs in the school setting. And actually, the recommendation reads that the implementation of suicide prevention programs in school settings that include mental health awareness training and skills training can be offered to reduce suicide attempts and suicide deaths among adolescent students. And this recommendation was based on a thorough review of the available evidence. And the recommendation is conditional, and the quality of evidence is low. And that's mainly due to the fact that there is very little evidence. I mean, unfortunately, we don't have many studies that evaluated interventions to promote mental health and prevent suicide in schools. And then the remarks are also important because even they should be, they have been found effective, even if, as I mentioned, the quality of the evidence is low. But one issue is that this is why the strength of the recommendation is conditional, is that there could be potential harms through a lack of healthcare and community resources to provide care for at-risk adolescents who seek help. So all the interventions that we have that are to be done in schools, actually they have the objective to increase help-seeking behavior. And if this, if an eventual increase in help-seeking, it's not met by community resources or healthcare resources, this can be even harmful. This is very important, and I'll come back to this concept later on. Most interventions that have been evaluated in the population of adolescents of between 14 and 17-year-old. And then the last remark is that all programs should be adapted and to contextualize locally. That means to local religion, cultural, and legal settings. And this should be, of course, done in a sensitive and appropriate manner. So that means that at least in my view, that means that all adaptation should always be done bottom up. I mean, starting from what are the opinions and experience of the end users locally in a local place. Okay, so I will now move on and from this introduction and speak about the SEYLE project and describe some studies that originated from the data set that from a large data set that we collected during the course of this project, because SEYLE was a study that was performed on 11,000 adolescents in 10 EU countries, and had two main objectives. So the first objective was to gather information on the European adolescents regarding their mental health, their well-being, their risk behaviors, and suicidal behaviors and bullying. And the second objective was to develop and evaluate school-based mental health promotion and suicide preventive interventions. So this was the research consortium. So these are the countries in Europe that participated in this project, which was funded by the European Union. From Sweden, we coordinated the consortium, and the other countries were chosen in order to provide the best possible geographical distribution in Europe. And what we wanted to do is to actually evaluate different approaches to school-based mental health promotion, which were based on different actors. So we wanted to evaluate an intervention that was empowering teachers and actually all the adults that are around the schools. That means teachers, but also other school staff. And for this, we imported a US program that it's called QPR, Question, Persuade, and Refer, and it's designed by the QPR Institute. Then we wanted to test, to evaluate a program that was based on professionals, so that, and we evaluated a screening that we developed ourselves in Sweden, together with our colleagues from University of Heidelberg that were participating in this project. And the third approach was to work directly with the pupils. And for this, we designed an awareness increasing intervention that is called YAM, Youth Aware of Mental Health, that it was also designed by us and by Columbia and at Columbia University in the US. So let's speak a bit about these different approaches and these interventions. So starting from gatekeeper training, this is the intervention that we used with school staff. And basically by gatekeeper, we mean anyone who is in a position to recognize a crisis and warning signs that someone might be contemplating suicide or have mental health problems. And so we trained gatekeepers about how to recognize signs and symptoms of suicide and eventually refer identified subject at risk to appropriate help resources. And basically the content of the teacher training was a one-day training, which includes some general information on suicidal behavior and information about the epidemiology of suicide. There was a specific training on what are the risk factors and warning signs for suicide. Then there was a section about myths and facts about suicide. And a section about how to ask, not ask question, how to provide support, and how to refer students at risk. The second intervention was a multi-stage screening. So there was the administering of a questionnaire to all students in the classroom. Then the data were processed to identify which students met predetermined cutoffs. And then those who scored positive at the questionnaire were asked for an interview to assess if they were in need for further referral or not. And one thing that I want to mention here, there are some challenges with screening, because that connects to what I mentioned before, and that what it's available in terms of mental health resources outside the school, in this case, it's extremely important, because increased identification of students in clinical needs actually leads to a greater access to mental health services. So even if we have plenty of evidence now that there are no iatrogenic effects of suicide screening, we still have to be very mindful about what kind of resources are available afterwards. And another problem is the risk of over-identification of children. So there is a high risk of false positives, especially at the first stage. That's why it's always important to have a second stage. And then there is an issue that it's related to informed consent, because of course, to perform a screening program, we need consent from children, but also from their caregivers. And this might be an issue in some cases. And I'll show you, when I'll show you the results of this project, that this was a very important issue. And the third approach that we use directly with young people, it's called Youth Aware of Mental Health, or YAM. And basically, this is based on the participation of young people in the classroom. So it was a 5-hour program that consisted in one presentation, discussions, and role plays about mental health. And moreover, all students were given a booklet with information about mental health, and there were some posters with the same information that were placed on the walls of the classroom. And what is the purpose of this program? It's to integrate different kinds of learning. So basically, we develop cognitive learning through a lecture and through the information that it's provided in the booklet and the posters. And there is also a component of experiential and emotional learning that actually happens through the role play. So this is the design of the study, which was actually a randomized controlled trial. So there was a selection of 168 schools, which were randomized to 4 study groups that were actually the teacher training, the professional screening, YAM, and control. And we had a baseline evaluation that was the same for all students that participated. Overall, there were more than 11,000 students participating. Then there was the intervention that were standardized to a duration of 3 weeks, each intervention. And there was a follow-up after 3 months and another follow-up after 12 months. One thing that it's important to notice is that the control was not a plain control, because for ethical reasons, we were not allowed just to have a plain control. So there was a minimal intervention that was also performed, on in the schools that were randomized to control. And this intervention basically only included the posters, the same posters that were used in YAM. However, before I go to the results of the randomized controlled trial, I mentioned that one of the 2 main objectives was actually an epidemiological objective, and it was about gathering information about the prevalence of risk behaviors and psychiatric symptoms. And this is a table that shows actually the prevalence of risk behaviors stratified by age. So as you can see in our sample, we had subjects that were 14, subjects that were 15, and subjects that were 16. And in all of them, we looked at alcohol abuse, illegal drug users, heavy smoking, reduced sleep, overweight, being overweight or being underweight, having sedentary behavior, excessive media usage, or truancy, so skipping school. And now, apart from the absolute numbers that, of course, these are the averages, but were different by country. But what we believed was striking in these numbers is how they increase almost linearly according to age. So all these risk behaviors actually increase already when between 14 and 15, and again between 15, they more than double up between 15 and 16. And this is an indication of how important it is to act early, because we know that these risk behaviors, that they are established, it's very difficult to make interventions on them. While when we were looking at psychiatric symptoms, so we looked at depression, anxiety, and subthreshold conditions of depression and anxiety. We had the SDQ in our questionnaire, so we looked at emotional symptoms, conduct problems, hyperactivity, peer problems, and lack of pro-social behavior. We looked at non-suicidal self-injury, suicidal ideation, and lifetime suicide attempts. In this case, we didn't find major differences related to age, but we did find differences related to gender. And we actually found, as it was expected, because this is information that was already in the literature, we found that internalizing behaviors are more common on average among girls, while externalizing behaviors such as conduct problems, hyperactivity, lack of pro-social behavior, and peer problems were more common among boys. And then if we look at the two bottom lines of this table, we see that suicidal ideation, here we mean all kinds of suicidal ideation, even a specific suicidal ideation, was very common, more among girls. Almost, if we look at both genders, approximately 1/3 of the sample showed some kind of suicidal ideation. And when we looked at lifetime suicide attempts, we found that 3% of the boys and 5% of the girls reported a suicide attempt previous in their lives. So what is the practical impact of this? What does it mean? That if we look at an average classroom of 25 to 30 pupils, we would have at least one that it's likely to have previously attempted suicide, at least another one who is likely to have had severe suicidal ideation, active severe suicidal ideation. So it reports severe suicidal ideation in the previous 2 weeks. And 5 to 10 pupils have experienced some kind of suicidal ideation during their lives. A study that we did on these risk behaviors was to see how they cluster together. So we used a latent class analysis that actually finds clusters of within the study population that is not without any a priori assumption. So we looked at all these risk behaviors, and we identified 3 groups that are here in these 3 columns. So on the left-hand side, there is a group that accounted for 58% of the sample, approximately. And this is a group that scored low on most risk behaviors. While we find in the center of this graph, we found another group that accounts for approximately 13% of the sample that scored high on the most risk behaviors. These 2 groups were rather expected because we know that risk behaviors tend to cluster together. But what was a bit unexpected was the other group that we found that it's on the right-hand side of this graph, that it's rather large because accounts for 29, almost 1/3 of the sample. And basically, this group scored high on three risk behaviors: reduced sleep, sedentary behavior, and high media use. And this was interesting because we started reflecting and discussing on this group, and we ended up calling this the invisible risk group, because if you think about it, while the high risk group, so the one that scores high on all risk behaviors, including smoking and drug use and alcohol use, that's rather easily identifiable as being at risk. But those who actually use the media a lot probably neglect doing sports for the same reason, and do that at night as well, and so they lose sleep. Those are not teens that are immediately recognized by external adult observers as being at high risk. However, when we stratify the sample regarding mental health symptoms between these three groups, what we found is that what we call the invisible risk group actually had scores that in some cases, for example, for depression, anxiety, and suicidal ideation, were very similar to the high risk group. And for other symptoms and behaviors, such as hyperactivity, conduct problems, non-suicidal self-injury, and suicide attempts, they scored less than the high-risk group, but significantly higher than the low-risk group. So we wanted to look into this invisible risk group a bit further. And I just remind you, these were the three components. So lack of physical activity, reduced hours of sleep, and high media exposure. And we actually looked specifically at these. And we found that physical activity was actually a challenge. We found that only 18% of boys and 10.7% of girls actually were doing physical activities that met the criteria of the WHO guidelines. And we found that doing physical activity was associated with increased well-being and with reduced depression and anxiety. Then we looked at pathological internet use, and we actually defined that as an excessive of poorly controlled preoccupations, urges, or behaviors regarding internet use that leads to impairment or distress. And when we looked at the prevalence of this in the sample, we found that approximately 4% of the students had pathological internet use, and this was more common among boys. But when we looked at the subthreshold conditions, so at what we call the maladaptive use of the internet, we found that the prevalence was much higher, was approximately 13%. Had scores that were consistent with a maladaptive use of online resources. And when we looked at the association of pathological internet use and maladaptive internet use with mental health outcomes, we did find that those who had pathological internet use had significantly higher levels of depression, of anxiety, of conduct problems, and hyperactivity or problems with attention. And the same applies with suicidal ideation and suicide attempts. And this is another related study that we did, that this was actually on another sample, was another European project. It was a slightly smaller sample of 2,000 adolescents. And we think it's important because we tried to look what were how mental health outcomes were associated with the perceived consequences of using online resources too much. So we actually asked the students why they use the internet, what they use the internet for. And there were positive and negative options. So there was options like finding new friends, having fun, learning about things, but also possibilities of staying online longer than intended, choosing online activities instead of hanging out with friends, and staying up late and losing sleep, and feeling depressed or moody when they had no access to online resources. And the results are interesting because basically what we found is that only the internet use that was resulting in sleep loss and withdrawal was able to predict longitudinal changes in mental health. That means that, according to our data at least, it's not the use of the internet by itself that actually is linked to the negative mental health outcomes, but actually it's withdrawals from usual activity and losing sleep. And we know now from a large body of research that sleep is very important. In our study, we found that students were sleeping approximately 7.7 hours per night, and we found that the hours of sleep were decreasing with age and were less among females. And we also found that reduced sleep was associated with emotional problems, hyperactivity, conduct problems, conflict with peers, suicidal ideation, and total emotional difficulties. Okay, I think I'm a bit short on time, so I will skip a few slides and I will just mention the main outcomes of the randomized controlled trials. So our outcome measures were the incident cases of suicide attempt, the incident cases of severe suicidal ideation, including having a suicide plan, and the incidence and prevalence of moderate or severe depression. We analyzed the data with a generalized linear mixed model, and all the results were adjusted by age, by gender, by country of residence, because remember there was these 10 countries in the study, by not living with both biological parents, not being born in the country of residence, so having an immigrant status, and by parental unemployment in the previous year. So regarding the QPR intervention, this was the teacher training. We found that the students that were randomized to this intervention did not have any difference in suicide attempts, suicide thoughts, or in the incidence and prevalence of depression. The QPR intervention had good was very well received by the schools. It probably was the intervention that they liked the most. However, we found, I didn't mention that during these projects, we also collected a lot of collateral information. So we administered questionnaires also, for example, to teachers and to all the school staff and to parents. And by correlating these data sets, we found that the preparedness to help pupils was correlated to the teacher's satisfaction with their work and with their own well-being. When looking at the results of the screening, we found that the screening did not have an effect on suicide attempts or ideation or in the incidence of depression, but it was actually effective on the prevalence of depression. So it was effective on those who actually had depressive symptoms already in the beginning of the study. However, the screening, as I mentioned, was a bit problematic. In total, we screened more than 3,000 students, but only half of them attended the interview, actually a bit less than half. So this is the problem of consent that I mentioned earlier, that actually more than half of those that were screened positive refused to attend the interview, mostly because their parent didn't consent to it. However, we found that there were external factors that were actually increasing what we call help-seeking behavior. And by this, we mean their acceptance of the interview and the overall screening process. And I found that this was more for younger pupils and those who were bully victims and those who were depressed or had suicidal ideation. And we also found that a positive attitude of the parents And also the geographical proximity of the school to where the clinical interview was held was actually a factor. And then relating YAM, we did find that YAM had an effect in reducing the incidence of suicide attempts and the incidence of suicidal thoughts and plan, and also the incidence of depressive symptoms. We didn't find that the intervention was effect on the prevalence of depression. So that means that this intervention showed good preventive effects, but not treatment effects. And when we calculate the number needed to treat or to prevent in these cases, we calculated that it's 91. So that means that combining the two outcomes, if the intervention it's done with 90 pupils, that means 3 classrooms, European size, then we would prevent 1 new case of suicide attempt or 1 new case of severe suicidal ideation. Main limitation and strengths of this study. Main limitation is that we rely on self-report. So of course, it's an issue, but unfortunately it's not possible to collect data on such a large sample with other means. And the other limitation is what I mentioned before, that the control group was not a plain control, but was actually exposed to some kind of intervention. And the strengths are that it was a large multinational effort involving 10 European countries. It was a very large number of adolescent participants. The participation rates were high, so at follow-up we had more than 80%. And the method was standardized with an active central oversight of the project management, data management, and also training of all those that participated in the programs. In the program was done centrally. So why do we think that YAM is effective? I mean, these are hypotheses that we're testing now, and we are starting to get good results. We are having some good results which are not published yet. So we think that YAM, it's effective, of course, because it increases awareness and knowledge about mental health, but also because it gives opportunity for reflection, improves classroom climate, enhances empathy, and promotes help-seeking behavior and peer help. This is how the program is structured. So it's done over 3 weeks. In the first week, there are 2 hours opening session and 1 role play session. On the second week, there are 2 role play sessions. And then on the third week, there is a closing session. So it's 5 hours overall. And this is this is my last slide. This is the booklet that we give and what are the contents. These are the themes that are addressed by the program. So we speak about what is mental health. We speak about, we give advice for self-help. We discuss what is a stress and what is a crisis. We go deeper into what is depression and what is the difference between ordinary sadness and clinical depression, and we discuss suicidal thoughts. And we discuss specifically how to help a friend in need, and we give specific information that it's localized about where to whom teens can ask for advice. So I'll stop here because I think I'm out of time.